So what is so characteristic about ventricular septal defect? We all are aware that there is a physiological derangement in the ventricular wall. Okay, so it can be again of further different types. It can be, small. If it is small, it will be restrictive. Okay, it can be, so that's why it can be restrictive, moderately restrictive. Okay, so there can be different types of that. So if a patient is having a restrictive VSD, most commonly it may even have a normal ECG, but in the V1 ECG you can notice is R dash pattern. Okay, and if it is associated with septal aneurysm, there can be increased incidence of the rhythm and conduction disturbances. Is that okay? So what is the typical thing about this? Because this is a moderately restrictive. So what is going to happen is two things you will be able to notice. The NA left atrium enlargement is going to happen, and also the LV volume overload. So that is also going to happen. So how do you notice for the LA enlargement? If you will look carefully over here, so for example, what about the other features? What other features you will notice? So for example, in this ECG, what do we notice? So over here, definitely axis is pretty normal, right? And then we notice is the left atrial enlargement. So the first deflection of the ECG is always for the right atrial, and the second deflection is for the left atrium. And especially if there's negative component is prominent, it again will point towards the left atrial enlargement. Okay. So how do you comment about the volume overload? For example, for the LV. You notice there's tall R wave and tall peaked T wave in the inferior leads. So here you notice those 2, 3 AVF, right? So in these three, what do you notice? As I said, this R wave is pretty tall, pretty tall. So this is why it is going to be a volume overload. Moreover, other than that, you also notice there's prominent Q waves and tall R waves with tall peak T waves in the V5, V6. Isn't it? It is pretty tall. So that's why it shows further the volume overload is there. There's some Q waves as well, isn't it? So this is not due to myocardial infarction, but this is due to volume overload. Yeah? Restrictive, we are aware, not much of changes will happen. Moderately restrictive, we are aware. Then, how about the non-restrictive ECG? What will happen in the non-restrictive ECG? In the non-restrictive ECG, as we can see it over here, there's peaked P waves, isn't it? From V1 to V4, tall and peaked. And there is also signs of the right ventricular hypertrophy. And how do you say that? Because in the V1 to V4, you notice the prominent R waves. Yeah? Prominent R wave in V1 to V4, and V5, V6, you see prominent S wave, in fact. And also, there's also left ventricular hypertrophy. Left ventricular hypertrophy, that there are different criteria if you'll try to just see the AVL. Otherwise, also the sum of the R wave in V5, V6 and the sum of the S wave in the V1 and V2 as well. There are different criteria for that. We have already covered those in the earlier sessions. So how do you classify the ventricular septal defect? To make it a little bit easier, as I had already said it, there are two things which can happen. One is only the left ventricular hypertrophy will happen, otherwise both sides will get hypertrophied. If both sides are getting hypertrophied, it simply means Only one thing. It means is it's a non-restrictive type. Otherwise, if it will be left ventricular hypertrophy only, so it can, yeah, 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 yeah. Is it better now, or is it still echoing? Just a second. Let me try to use another microphone. Just a sec. Hello. Now is it better? Oh, wonderful. Maybe it was the headphone problem. Okay, good. So yeah, thank you. So as I was talking about the different types, so we should be able to understand the mechanism as well, what is happening. So as we are now already aware about the VSD algorithm, so the other thing what we all have to keep on thinking, as I had said it, for example, the non-restrictive VSD, so there will be a large left to right shunt, and that is the reason in the ECG as well, which I had shown it, we do expect a right axis deviation. There will be a right atrial or combined right and left atrial enlargement. Similarly, we can notice what is called as a biventricular hypertrophy. I showed you an example, isn't it? So that is what is called as the Katz-Wachtel pattern. Okay, Katz-Wachtel pattern. So Krukita's sign was for the ASD. The Katz-Wachtel pattern is for the VSD. Okay, but if it is biventricular hypertrophy, right? Similarly, if you will be able to notice, as I had said it in the non-restrictive VSD, simple, think it like that. Why is it non-restrictive? If there is no restriction because of the by both the sides the flow is happening. So that's why there will be biventricular hypertrophy. The LVH will also happen, right ventricular hypertrophy will also happen. That is why, as I already showed it to you, there will be tall R waves in the V1, large diphasic RS complex in the mid precordial leads, and deep Q waves with tall R waves and deep D waves in V5 to V6. Okay, so that's what I was trying to tell, isn't it? So what do we notice in this one? So there are other ways to define the perimembrane VSD as well. So for example, it can be inlet VSD, multiple VSD, or perimembranous VSD as well. So on the basis of if for the perimembranous VSD, if because they can be associated with septal aneurysm, so one can expect a left axis deviation for that. Similarly, inlet VSD can be there, which can have a counterclockwise loop. That's why we notice a left axis deviation but with prolonged RI interval. Similarly, for the multiple VSD, we notice clockwise loop with left axis deviation, isn't it? So how about this Eisenmenger syndrome? We all remember. What is Eisenmenger syndrome? Okay, we'll speak about it sometimes later and all. But uh, so common things, at least what we expect is, see, ASD, VSD, and PDA, we all are aware that they are different entities. However, their presentation can be a bit similar. So what is called as P pulmonale. So P pulmonale will refer to the right atrial enlargement. So the right atrial enlargement can be expected at least in quite a lot of cases of the ASD, but less unlikely in the VSD because everything in the ASD is happening on the upper chambers. So you can expect it more often. Okay. And the VSD, of course, goes to the lower chamber PDA even further. So that's why the RVH, for example, the RVH will happen most commonly in the ESD, but only in the less oftenly in the VSD, and maybe similar or even a little bit less in the PDA as well. Okay. If you will recall, what are the conditions in which we can expect Q wave in V5 and V6? Can anyone recall for that? So Q waves we expect in the V5 and V6, especially in the volume overload. So what are the conditions in which volume overload we can expect in the PDA and occasionally, of course, in the VSD as well, which we already gave you some of the examples. So one of the important things we all are concerned, how about the severity of the shunt? So for example, it will depend uh, how is the shunting is happening. For example, if so it can be again mild, moderate or severe. So if you look at the pulmonary flow to the systemic flow ratio, if there is more of pulmonary flow or is it more of systemic flow, and on the basis of that you can again uh, with this ratio you can comment on the size of the shunt as well. Okay, if the ratio is less than 1.4 it will be mild, but if it is more than 2 it will be severe. Similarly, if you notice there's a right atrial enlargement, so you can already notice, so most of the things are going in the right side rather than going to the left side. So of course, if right atrial enlargement, do you notice, chances will be it to be more towards the worst side, so it is moderate or severe. Similarly, for the RV volume overload, again it can be moderate or it can be severe, isn't it? And then similarly for the croquetage sign will be, again as I had said, it is what happens is this will be more of the severe sign. And isn't it the reason as well I had said it? What do we notice during the croquetage sign will be the fragmented QRS, especially in the 2-3 AVF. And we can also sometimes notice the evidence of the PAH, pulmonary arterial hypertension.